right, so I am Ryan Feldman. I am an emergency medicine pharmacist at Froedtert Hospital and one of the clinical toxicologists with the Wisconsin Poison Center. Thank you to all of you for tuning in today to listen to our webinar presentation, Where There's Smoke, There's Fire, E-Cigarette and Vape-Associated Lung Injury, also known as, hey, who still remembers EVALI from a few months ago? I know there's been a lot of information in the news about coronavirus, but this was a thing just a few months ago, and there's still a lot of questions about it. So we are going to do a deep dive and see what questions we can answer for you. So I'll be presenting the first half, and then Matt Stanton, as you should all know, my colleague, also emergency medicine pharmacist and clinical toxicologist, will be taking the second half, focusing on clinical management of EVALI. Let's get started. So we have nothing to disclose today. Neither Matt nor I are current e-cigarette or vape users. And our objectives, we're going to describe the history of vaping-related health concerns and the EVALI outbreak, discuss the products that have been associated with EVALI, and try to explain the role that vitamin E acetate has played in the EVALI outbreak. Lastly, we'll summarize CDC treatment recommendations if you are to encounter an EVALI patient. So let's start with Dan. Dan is a 23-year-old male who presents to a clinic for cough, chest pain, and nausea times one day. His roommate was recently diagnosed with influenza, or possibly coronavirus, and his past medical history is none. He's a current cigarette smoker and e-cigarette user. So, with this concerning set of symptoms and all these outbreaks of disease in today's day and age, this brings up a lot of questions. Does Dan have EVALI? Should Dan be admitted to a hospital if he does have EVALI? Should imaging be performed? What kind of labs should be done? And what therapies should Dan receive if he does have EVALI? These are all questions that we are going to dive into, but first, we're going to look at what caused this whole problem in the first place. So, before we move on, a few definitions just to make sure everyone's on the same page. Vaping is considered the use of an electronic cigarette. So you might hear me say e-cig or vape. I'm talking about them interchangeably. THC, I think most people are familiar with. That is the psychoactive component of marijuana or cannabis. CBD or cannabidiol is a non-psychoactive component of marijuana. And it is something people like to put in vape pens and inhale. And then BAL or bronchoalveolar lavage is a sample of lung fluid that we can run some tests on, and we talk a lot about it in this presentation, so wanted to make sure it was clear. So a little history. In 2003, a Chinese pharmacist named Han Lick invented the e-cigarette as we know it today. It was invented as a nicotine replacement device. It was a battery that powered an atomizer, which heated a cartridge of fluid. And that fluid was usually glycerol and propylene glycol and nicotine. And it would atomize, it would heat that and vaporize the fluid, and you could inhale it and absorb that nicotine without absorbing any smoke. Every e-cigarette since has had the same sort of design. We have a cartridge with our liquid of desired choice, be that nicotine, THC, CBD, or flavoring, an atomizer that vaporizes that liquid, and a battery that powers that atomizer. They come in many different shapes and sizes, pens, USB-style vaporizers, and we've got tanks, pipes, cigars, mods, rechargeables, disposables, you name it. They entered the U.S. market in 2007 and were aggressively marketed. By 2014, they were the most commonly used youth tobacco product, likely due to their perceived low adverse health effects because it's not smoke. So they're being used among smokers and non-smokers alike. If we look at a 20-year trend of 1 month use of cigarettes amongst high schoolers, you could see that's been on a pretty significant decline compared to e-cig or vape products, which have been on a meteoric rise in the last few years. In fact, in the 2019 National Youth Tobacco Study, it was estimated that nearly 1/4 of all high school students have been using an e-cigarette, and some 5 million current youth were e-cigarette users. So that's roughly the size of the state of Wisconsin, full of youth using vaporizers. So, when this disruptive technology came to the market, there were quite a few health concerns that started cropping up. First was exploding batteries. These weren't very well regulated devices, and sometimes the batteries would overheat and explode. So, we'd see burns and traumatic injury in the places where they were commonly kept. So, either of the face or of the thigh or breast pocket. Then we saw overdoses of concentrated liquid nicotine. So you have to use these concentrated nicotine liquids to fill the device. And for reference, one cigarette has about 10 milligrams of nicotine within the dried tobacco leaves. These e-liquids can have up to 100 milligrams per milliliter of solution, of nicotine in solution. And with pediatric fatalities as little as 50 milligrams, that's 5 cigarettes or just half a milliliter of solution. And there has been an increase in electronic cigarette and liquid nicotine cases reported to U.S. poison centers over the last few years. Then we started to see diseases that we normally associate with smoking. So things like acute eosinophilic pneumonia, other things like respiratory bronchiolitis, interstitial lung disease. And then we saw diseases that we normally associate with exposures to certain chemicals. So bronchiolitis obliterans is also known as popcorn worker's lung. It's thought to be a condition caused by exposure to diacetyl, which is a component in buttered popcorn flavoring. And we do find diacetyl levels in e-cigarettes, but they're generally at levels that are lower than regular cigarettes. We've also seen things like giant cell interstitial pneumonia, which is also called hard metal pneumoconiosis, and that's known to be associated with cobalt exposure. And as it turns out, some of these metals from the atomizers can actually get pulled through and wind up in the vaporized or the vape uh, cloud, I guess you would call it. And then we've seen things like lipoid pneumonia, which is something that's pretty well associated with chronic lipid aspiration. So, with all these kind of chemical exposure related diseases, it led to a lot of scrutiny over what exactly is in these vape pens or the vape aerosols that they generate. So, there have been a fair amount of studies that have looked at this. And if we look at the liquids, yes, they have glycerol and propylene glycol and nicotine, like they say. But we also find things like acetone, acrolein, formaldehyde. And if we look in the aerosols, okay, we see the normal listed ingredients, but we also see things like acetone, formaldehyde, metals being pulled through from the atomizers or toluene. So certainly some potentially toxic compounds are found in liquid and aerosols from vapes. However, when you do the head-to-head, they're generally at lower concentrations than cigarette smoke. So the generally adopted viewpoint of society at this point was, well, yes, they're less damaging than regular cigarettes, but more damaging than nothing at all. Then, on August 1st, 2019, the Wisconsin Department of Health alerted the CDC to a cluster of severe lung injuries, all in primarily younger patients with no other identifiable cause beyond they all used a vape in the last 90 days. This prompted the CDC to begin syndromic surveillance, and states were then required to report cases of potential e cigarette or vape associated lung injury to the CDC. So, what exactly is EVALI? Well, it's a syndrome, which means it's a constellation of symptoms. We see respiratory, gastrointestinal, and constitutional symptoms. We can have things like shortness of breath or chest pain, nausea, vomiting, or diarrhea, fevers, and weight loss. And if you're thinking that sounds exactly like your typical influenza symptoms, you're correct. The key difference here is that there is no identifiable cause for these symptoms. So, infection, rheumatic, and malignant disease that might cause this has all been ruled out. And the patient must have used a vape within the last 90 days to be considered an EVALI case. The types of symptoms that we see will differ depending on which case reports you look at, but frequently you'll see respiratory symptoms. There's frequently positive X-ray findings. In the largest case series, 91% had positive X-ray findings, and 100% had positive CT findings. And you're actually more likely to see all the symptoms together. Even though it's called lung injury, only 9% in some case series had just respiratory symptoms. Most had both respiratory, gastrointestinal, and constitutional symptoms combined. The clinical course of EVALI develops over days to weeks, and it frequently requires intensive care. So, intubation is commonly reported in up to a third of patients. Extracorporeal membrane oxygenation has been used, as well as lung transplant. And the mortality rate is reported to be nearly 2.1%, which is concerning given that this is a primarily younger population that it's affecting. So the CDC has these long definitions for what a confirmed versus a probable case of EVALI is, and you can read through everything here. But the long and short, a confirmed case of EVALI is a vape user with no other plausible diagnosis for their symptoms and all of the appropriate labs done to rule out other possible diseases. A probable case of EVALI is a vape user who might have co-infection with influenza or pneumonia or coronavirus, and maybe not all of the appropriate labs have been sent to rule out other diseases, but the treating team still believes it could be EVALI. So, as of February 18th, 2020, there were nearly 3,000 hospitalized EVALI cases from all 50 states and the District of Columbia and the U.S. Virgin Islands and Puerto Rico, and there were 68 reported deaths from 29 states and D.C. Seems like a small number in the midst of our current outbreak, but these are very young patients that are generally being affected. Peak reporting occurred sometime in September, and really we've seen a significant drop-off since then. But the EVALI patient themselves, 67% were male, and their vaping patterns varied. So 80% reported using a THC product of some kind, 13% reported using only nicotine products, 1% used only CBD products, and 5% reported none of those things. So maybe just using flavorings or some kind of a home-cooked product. The median age was 24 years old, so very young patients, probably reflecting the demographic that uses vaporizers. And 95% of these younger patients required hospitalization, with up to a third needing intensive care. So given the drastic healthcare utilization and severe manifestations of disease in these younger people, it prompted the CDC to start searching for a cause. So the CDC developed a surveillance team, and they began testing submitted samples from EVALI patients. So they tested the vape products themselves, aerosols from the vape products, and lung fluid from patients who had EVALI. They were testing for what are called priority toxicants, and they listed them here: vitamin E acetate, plant oils, medium chain triglyceride oil, coconut oil, petroleum distillates, and diluent terpenes. So from plant oils to diluent terpenes, these are relatively well characterized as hydrocarbons, which have a pretty good storied history of causing chemical pneumonitis when aspirated or inhaled in the lungs. Vitamin E acetate's history of pulmonary injury is not so clear. But vitamin E itself is another word for tocopherol, and there's a lot of different tocopherols. The one we're talking about in the outbreak is alpha tocopherol, and the ones that humans are usually interacting with are alpha and gamma tocopherol. It can be found in dietary supplements, cosmetic products use vitamin E, and as of recently, e-cigarette or vaping products as a diluent. So it's used to dilute out your more expensive THC oil so you can make it last longer. And generally, it's found in unregulated THC products purchased from informal sources. So it's sort of a cutting agent. So how does vitamin E acetate cause toxicity? Vitamin E itself is not toxic via the oral or dermal route. Well, we really don't know, but there's a few theories. The reason that you hear it called vitamin E acetate is because we don't know if it's the acetate or the vitamin E or both that could be causing toxicity. The molecule itself is here on the right, and it's a molecule of acetate and a molecule of vitamin E linked together by an ester link. There's a few proposed mechanisms. Some think that the surfactant, or this long fatty acid chain, can interfere with surfactant in the lung and interfere with our ability to exchange gas. And there's also other theories that acetate, when it goes under vaporization, actually becomes, or pyrolyzation, so heating without combustion, They think that it'll actually get cleaved off and produce a compound called ketene, which is a pretty well-known pulmonary irritant and is known to cause things like delayed pulmonary edema. And currently, the CDC has been attempting to quantify levels of ketene in the EVALI lung, but we don't have any results from that at this point. So, is there any data to support that this is toxic? So far, all we actually have are theories. So, myself and colleague Matthew Stanton searched medical literature databases for pulmonary effects of vitamin E acetate or vitamin E or pyrrolized acetate in humans. We chose pyrrolized acetate because there's already studies that demonstrate that inhaling acetate when it's attached to other compounds like gluteramine doesn't really have any negative pulmonary effects. So we came up with 783 articles that we identified, and after reviewing them by abstract and title, we found about 200 total articles looking at tocopherol and lung after exposure. Finally, we narrowed it down to 14 articles that looked at the effects of inhaling tocopherol on pulmonary tissue. So 11 of the 14 studies looked at sheep or mice, and they exposed them to some toxin like paraquat smoke or maybe a bacterial toxin. And they compared that to sheep or mice that were exposed to the same toxin plus vitamin E. And overall, they found that inhaling vitamin E actually protects you from oxidant or inflammatory induced lung injury. 2 of the 14 studies also looked specifically at vitamin E acetate. So they took mice, exposed them to either lipopolysaccharide, which is a bacterial toxin, or oxidant. And they compared mice who got vitamin E acetate and the same toxin. Well, what they found was control mice had no change in their surrogate markers for pulmonary damage. Those who were exposed to just the toxin had big increases in their surrogate markers. If you got toxin and vitamin E, it was protective, so vitamin E actually protected, but toxin and vitamin E acetate was not as protective. Although if vitamin E acetate was a toxin, I guess you would kind of theorize that you'd actually see more damage if you're adding 2 toxins to the mix, but it's very hard to extrapolate animal data. And we don't know if the effects on the lung were due to the toxin itself or the vitamin E acetate. There's no real way to differentiate. There's only one single study that was published in 2020 that looked at mice who were exposed to aerosolized vitamin E acetate for 2 weeks compared to aerosolized e-cig diluent for 2 weeks, being propylene glycol and vegetal glycerin, or nothing at all. And when they looked at their markers of inflammation, well, the control group, they had no change in lung albumin levels, which is sort of a marker for how leaky the vessels in the lungs are. If you were exposed to propylene glycol or vegetable glycerin, you had an increase in your markers of lung inflammation and damage. And vitamin E acetate alone had the largest increase in lung inflammation markers or damage. Okay, so maybe there's some data with mice, although largely a lot more is needed. In fact, there's been such a lack of literature around this that this very small mouse study actually got published in New England Journal of Medicine. So that just shows how much more data we really need. If we look at the animal data for oral exposure, there's a ton of kind of conflicting information. There is some data that gamma tocopherol can increase neutrophil recruitment, and alpha tocopherol actually reduces neutrophil recruitment and prevents airway hyperreactivity. And there was one study that found that massive doses of alpha tocopherol for 13 weeks caused rat lung inflammation, along with a ton of other organ system damage. And there are literally hundreds of studies, it seems, that actually support oral tocopherol seems to protect against lung injury in most animals. So the animal data is conflicting. Vitamin E acetate might have some negative data. Vitamin E seems to be protective, but overall, there's quite a lack of information. Nevertheless, in November of 2019, the CDC took 29 lung fluid samples from 10 different states, all from EVALI patients, and they tested them for vitamin E acetate. None of the other screened priority toxicants were present, but vitamin E was found in vitamin E acetate was found in every single EVALI BAL. So it appeared that vitamin E acetate is present in the EVALI lung. Then, to strengthen the association, they managed to accrue a total of 51 EVALI BALs and tested them all for vitamin E acetate. 94% were positive. They then compared this to 99 healthy individuals. This was from a few years worth of people, and only 9 of them from the year of the outbreak. But 0% of these healthy individuals, which were a mix of cigarette smokers, smokers, and never smokers, tested positive for vitamin E acetate. So it appears that vitamin E acetate was absent in healthy lungs, but present in EVALI lungs. At the same time, Minnesota began testing vape products and liquids that were seized from illegal vape distributors. The 2018 products that they tested for vitamin E acetate and medium chain triglycerides only contained medium chain triglycerides. There was no vitamin E acetate to be found. The 2019 products that they tested had a significant amount of vitamin E acetate in the products that they tested. So it appeared that vitamin E acetate was absent in illegal 2018 products, but present in the 2019 products during the time of the outbreak. Finally, they started testing products that were submitted by EVALI patients. So they took 12 EVALI patients and tested all of their THC products. 11 of the 12 were able to produce at least one THC product with vitamin E acetate. The one of 12 that didn't submit all their products. So it's possible they had one at home that had vitamin E acetate. And they tested all of their nicotine products that they could find. And out of 21 tested products, none had vitamin E acetate. It would appear that VEA was present in at least one THC product owned by EVALI patients, but absent in their nicotine products. And as of today, well, actually, there's been a lot more testing. This isn't an updated slide. They've tested nearly, I think, 900 different products. Roughly 60% are THC positive. These are all products that are connected to an EVALI patient. And 50% of those THC products tend to contain vitamin E acetate. No nicotine products have been reported to contain vitamin E acetate that have been tested. So it appears that THC products are associated with vitamin E acetate, and vitamin E acetate is associated with EVALI. If we look at the products that are used by patients with EVALI, there are over 152 different brands that have been reported, but some prevailing themes seem to come about. So Dank Vapes is the most commonly reported brand, 56%. Rove comprises 12%, TKO 15%, and Smart Cart 13%. There is some regional variability. On the East Coast and the South, Dank Vapes is the most common. Here in the Midwest, Rove is the most commonly used vape product associated with EVALI. And in the West, it's TKO and Smart Cart. Those names might look familiar, as those were the products that were tested by Minnesota from illegally distributed or illegal distributors of vapes. And Dank Vapes, Rove, and TKO have all actually tested positive for vitamin E acetate. So it appears that VEA confirmed products are most commonly reported with EVALI patients. So did we find the cause? It seems like it's all these THC associated or these THC products contaminated with vitamin E acetate that is causing EVALI. At least that is what the media seems to think, and they really ran with that idea. But if we look at the vaping patterns of these EVALI patients, only 80% report using any THC. What's going on with my 13% that say I only use nicotine and 1% that say CBD or some kind of home cooked thing? Well, maybe it's underreporting. Maybe they are lying and everyone is actually using THC. And underreporting definitely was occurring. For instance, of all the patients who we tested their BALs, only 75% reported that they used THC. However, 85% tested positive for THC. But there are case series with patients who report not using THC and test negative for THC. So in Illinois, case series looked at 9 of these patients, and over 50% required ICU care because of their EVALI disease. However, it's noted that 100% of these cases were probable EVALI. So they didn't meet all the criteria needed to be a confirmed case. It's possible that it's a combination of underreporting and misclassification, but it's also possible that it's something else altogether. So when we actually look at the cellular injury patterns of EVALI, we see things like lipoid pneumonia, diffuse alveolar damage, acute fibrinous pneumonia, and organizing pneumonia. These are all nonspecific and don't necessarily indicate one single agent that could be causing toxicity. And other things have been found in EVALI patients, like limonene and coconut oil were found in the BAL of a few of the EVALI patients. Both are capable of producing pulmonary injury. Additionally, medium chain triglycerides have been found in about 30% of all tested THC EVALI devices. So, how do we know? Is vitamin E the cause of this disease or just the correlate? One set of criteria proposed by an epidemiologist named Bradford Hill helps us assess whether something might just be associated with disease or cause it. There's 9 different criteria. We're not going to spend too much time on it, but it'll help us get an idea of what else we might need to know before we can really lay the blame on vitamin E acetate. So let's start with the things VEA has going for it. It looks like it does have significant strength of association. So we've tested a small number of products in patients, but 94.1% were positive. Even if one non-EVALI patient tested positive for vitamin E acetate, it would still be an odds ratio of 144 to 1 for isolating vitamin E acetate from EVALI patients. The timing seems to fit. We weren't finding it in 2018 products, but we did find it in 2019 products during the time of the outbreak. And there is theoretic plausibility. So ketene production may be interfering with surfactant or causing inflammation. At least in theory, it makes sense. But when we look at other things like consistency, well, we found it in EVALI THC products, and we haven't found it in healthy lungs. We are finding it in EVALI patients. That's great, but we haven't found it in non-THC products. So what is causing EVALI there? How about coherence? There's a clear cause and effect. Well, the animal data that we have is conflicting. Some support positive effects from vitamin E, and there's some neutral or maybe negative data with vitamin E acetate, and there's some positive data with just acetate. Only one cause? Well, 0% of nicotine products tested were positive for vitamin E acetate, yet nicotine users are still affected. Other things might also be causing this. Multiple exposures could be causing the same syndrome. And finally, experimental data should support our theories. And there's very few studies, and those that we have are conflicting. So, in the end, EVALI is a syndrome. Multiple agents might create similar symptoms, sort of like influenza and pneumonia can both cause cough, fever, and shortness of breath. Vitamin E acetate might be a marker of other toxicant exposure, or it could be one of numerous chemicals causing EVALI. In the end, we're left with some known knowns, and that is that vitamin E acetate is associated with the EVALI BAL, and it's associated with unregulated THC products like dank vapes, TKO, and Rove. But we have many known unknowns. Is this the culprit or the correlate? What is associated with non-vitamin E acetate EVALI, and is there a safe product? Will vitamin E acetate appear in other products if we continue testing? Will we find other toxins? And lastly, who is responsible, and will this happen again? Because this is not the first time in even the last 5 years that we've had a massive outbreak of severe disease related to contaminated, unregulated products. So what's a vapor to do with all this confusing information? So no product is known to be safe. So the recommendation is that people avoid all e-cigarette or vaping products from the FDA. And if they were using e-cigarettes to stop smoking, it's recommended that they don't return to smoking cigarettes, as we know those are bad. So it might be a good time to look at FDA-approved nicotine replacement therapies. Finally, if the patient is unable to stop vaping, they should monitor themselves for symptom development and avoid unregulated or modified products, which are known to be associated with the disease. All right. Well, thanks for listening. With that, I would love to turn control over to my colleague, Matt Stanton, who's going to talk about clinical management. If I can figure out how to stop sharing my screen. There we go. Matt, all yours.
All right. Thank you, Ryan. Okay. Well, does everyone remember Dan? He was our vape user with a 1-day history of nausea, cough, and fever. And the question still remains, does Dan have EVALI? Well, the CDC has excellent guidance on their website on how to assess and manage these patients, whether you're inpatient or outpatient. We're going to step through this in the next few slides. So if you do have a patient that vapes, there's some specific questions you should be investigating in terms of their vaping habits. And the full list of these questions is available on the CDC's website. But what it boils down to is what products do they use? What substance do they use or think they use? Where did they get it from? When did they last use it? And is the product available for testing? The CDC does have resources on their website in relation to testing products and also testing specimens such as a BAL, blood, and urine. There's also testing information available for medical examiners and coroners. So in Dan's interview, Dan states, I use a blue e-cigarette regularly, as well as a pen my brother gave me called TKO, and a CBD pod mod only after exercise. I also have a Juul and an e-hookah I modded with flavoring. He last used any product this morning, and he only has the nicotine product available for testing if needed. So if your patient does vape, it's important to get a great history of his present illness, vital signs, work up a cause of symptoms, including evaluation of influenza and other respiratory infections, seeing that this is still a diagnosis of exclusion and the usual suspects should be ruled out. So going back to Dan, he's a 23-year-old vape user with cough and fever for 1 day. Physical exam shows it's benign, his lungs are clear. He's got a heart rate of 70, a normal blood pressure and respiratory rate, and his oxygen saturation is 98% on room air with a slight fever of 99.5. He has a retrocardiac infiltrate on his chest x-ray, and his influenza testing sent was negative. So, does Dan need admission to the hospital? The CDC has guidance for patients that do not need admission to the hospital. If a patient has normal oxygen saturation, they're not in any respiratory distress, they either have their comorbidities controlled or they don't have any comorbidities, they have reliable access to care, and they're able to follow up within the next 2 days. They can actually be a candidate for outpatient management. Applying this to Dan, he was eventually discharged with antibiotics for community-acquired pneumonia. He was instructed to stop all vape use and offered counseling for his nicotine use disorder. He was screened for and given an influenza vaccine, and he was instructed to follow up in 48 hours. 24 hours later, Dan calls the clinic back to report a worsening cough and dyspnea. He was instructed to go to the emergency department. If your patient needs hospitalization with EVALI, it's important to continue to work up the usual suspects with infectious disease, such as influenza, other respiratory viruses, and other respiratory cultures to assess bacterial infection. Getting a chest x-ray is important, as well as a CT if the chest x-ray is normal, but EVALI is suspected. The CDC also recommends getting urine toxicology. We feel this has a questionable utility. First, there is no guidance on the reasoning of obtaining urine toxicology testing or the analytical methodology that should be used, whether it's immunoassay, gas chromatography, mass spec, or some other confirmatory methodology. Second, urine toxicology testing does not give you specifics on timing, dose, route, or formulation of the substance. For example, a patient may be vaping only a flavoring product, but also uses THC edibles or smokes marijuana cigarettes. This patient may test positive for THC in their urine, but the vaping product does not even include THC. Obviously, with all toxicology consults, stopping the insult is important. Offering services to stop using, such as FDA-approved nicotine replacement therapy and addiction counseling, is important as well. Treatment will probably include empiric antimicrobials and or antivirals until infections ruled out. Patients may get oxygen with bronchodilators and corticosteroids. Consulting services should be involved, such as medical toxicology, pulmonology, critical care, infectious disease, and psychiatry and addiction, and others depending on comorbidities. In regards to corticosteroids for EVALI, there really is no robust comparative data. The majority of patients that have EVALI do receive steroids. There is some concern that steroids may worsen infections outpatient, and this should be considered a risk-benefit discussion based on the comorbid conditions. It's also reasonable to rule out other causes before administering corticosteroids. They are used more frequently in older patients, those with cardiac and pulmonary disease, and the majority of inpatient hospitalizations do receive steroids. The dosing varies from 0.5 to 1 milligram per kilogram methylprednisolone or equivalent daily. There is no set dosing for these patients, and these doses are usually the same doses used in other disease states. They are frequently given for longer than 7 days and may include a taper. There was a small analysis by the CDC which showed there was no difference in the percent discharged EVALI patients compared with those that were rehospitalized, died, and were either neither rehospitalized or dead. So looking back to Dan on hospital day 1, his vital signs show he was a little tachycardic, tachypnic, he was requiring oxygen to maintain a saturation of 94%. His physical exam showed cyanosis with coarse lung sounds. He was on high flow oxygen, receiving albuterol and ipratropium nebulizers, and he eventually was intubated for impending respiratory failure. The CT of his chest showed numerous ground glass opacities. His respiratory viral panel was negative. A BAL is sent for culture, and he had a leukocytosis on his other labs. The Poison Center is contacted for a medical toxicology consult, and pulmonary, rheumatology, and infectious disease are also consulted. On hospital day 2, workup for infection and rheumatic disease were negative. He was started on methylprednisolone, 40 milligrams intravenous every 12 hours. A BAL and his available vaping products are sent to the CDC. On day 3, his oxygenation slowly improved. Sputum cultures returned negative. His antibiotics were discontinued, and he was extubated on day 4. A usual hospital course for these patients will include airway management, admission to intensive care, possibly, systemic glucocorticoids, and the length of stay is varied from a median of 5 to 6 days if you're less than 50 years old, to a longer median stay of 12 days if you were older than 50 years old. These patients will also require a multidisciplinary care team. So when is it fine to discharge your patients? Well, if they have normal vital signs, if their symptoms have resolved, their comorbidities are controlled, they have reliable access to care and a good social support system, and they have reliable follow-up. The CDC makes a EVALI discharge readiness checklist, which goes through each step in order to discharge your patient safely. We also like to acknowledge the CDC for including inpatient pharmacist discharge medication counseling in this checklist. The reason the discharge process is important is because there was an analysis of 1,139 patients that showed 31 of the patients ended up being rehospitalized, with a median time of 4 days from discharge to rehospitalization. This analysis also showed that 7 of these patients died after discharge, with a median time of 3 days from discharge to death. The characteristics of these patients that were readmitted or died were they were older, with a median age of 27 years. They had multiple comorbidities, including diabetes, cardiac disease, and pulmonary disease. And then there was also potential that re-exposure to their vaping led to a recurrent disease. And this was all supported with a study that was released this past week in New England Journal of Medicine that looked at, as of January 7th of this year, 2,558 non-fatal cases and 60 fatal cases. There was an increased proportion of fatalities with patients with respiratory disease and cardiac disease. And this analysis also found mental health conditions and obesity were an increased proportion of fatalities that the CDC had not reported on. The study also found that the majority of non-fatal cases were more likely to receive corticosteroids as well. Applying the discharge readiness checklist to Dan on day 5, his vitals were normal with ambulation. A social worker met with him to perform a substance use screen. He was discharged on a home oral steroid taper. He was supposed to follow up with a primary care physician in 48 hours, pulmonologist in 2 weeks, and he had addiction to medicine appointment in 2 days for his nicotine use disorder. 3,000 days later, Dan trades in his vaping device for a diploma. Thanked everyone involved with his care, especially the pharmacy staff, gets a PhD, becomes a lead vaping researcher, and eventually wins the Nobel Prize in Medicine. There are many resources available on the CDC's website, including guidance for healthcare providers, surveillance, reporting, treatment, and testing. You can use the link on the bottom of the slide. Otherwise, it's easy enough to Google CDC EVALI. In closing, it's important to identify these patients and getting a great history on their vaping use. Supportive care is going to be the mainstay of treatment. Meticulous follow-up is going to be very important due to the amount of deaths that we're seeing in that analysis. This should be something where poison centers are included and also public health officials. We also feel vaping is going to continue regardless of regulation and restrictions. And there's still many questions that remain around what the actual cause is. Most of all, if you want to avoid complications from vaping and other things, we just advise that you don't do drugs. This is our contact information, along with our Twitter handles, the poison help number if needed. And these are our references. We'll take any questions at this time.
And Ryan, this is Dave Gumman. Can you hear me?
Yeah.
So if you, I want to thank both of you first for an outstanding presentation once again. This was really good and it was timely. If you look at the incidents and reports of EVALI cases from July till the end of last year, there's almost a little bit of overlap between then and the report of COVID cases. How would you distinguish before we were doing widespread testing whether the patient in front of you has COVID or has EVALI? Because I think a lot of the questions that were asked back in the fall were, oh, are you vaping? And now those questions have kind of fallen aside. And the only question is, have you been exposed to somebody with COVID?
Yeah, I think that's a great question. And I think the answer is that we don't know. Looking at the symptoms that have been reported, aside from just respiratory symptoms, there's gastrointestinal and other constitutional symptoms, which looking at the COVID cases, there is almost complete overlap with a number of these. So I think it's a great question, and I think the answer is that it is pretty much indistinguishable.
I wonder how many EVALI Matt, mute yourself. I'm gonna hear his echo right now. Thank you. I'm curious how many COVID cases, if they really went back to the EVALI. I wonder if radiographically there's probably some kind of a differentiator. I know there's pretty clear radiographic findings for COVID. EVALI has, they do have, I believe, multifocal opacities usually, but it would be really interesting to go back and look and see how many EVALI cases were actually, to be confirmed EVALI case, no infectious cause that we know of. Well, we weren't testing for EVALI at all for COVID during the time of the EVALI outbreak. So it'd be pretty fascinating to see if any of those were actually just EVALI in disguise that ended up, that were vapors. Okay. Any other questions?
It doesn't look like there's other questions in the chat or anything. So
Thanks again, both of you.
Thank you guys for tuning in.
no problem. Yeah, thanks a lot. I appreciate it. It was fun.